invite the next speaker, Professor Jagat, who really does not need any introduction. He will be giving his talk on what he has taught us all this while generating a state-of-the-art pediatric cataract surgery. So all of us know, have learned pediatric cataract surgery, the state-of-the-art, from wonderful presentations he's been giving. So Dr. Jagat, please.
Thank you, Professor Saxena. We have with us Dr. Pandey, Dr. Shekhar, and friends. I will be speaking on state-of-art pediatric cataract surgery. While actually I was not knowing the time, I made this presentation for 15 minutes, but then I reduced it to at least 8-9 minutes by knowing the time that it is only 7-minute time. It was 15 minutes presentation. Anyway, I will try to finish in time. No, I think I will not ask time because till the next speaker, he is on the way from the airport when he comes. But before that, I will stop, no issue. My experience in this field is almost 42 years and 4 months at PGI and now one year addition. So I have worked in the field for more than 40 years. From a very small beginning, year after year, I have diligently worked to serve the thousands of the children who were brought with millions of hope at our doorstep, and to educate hundreds of the young minds who want to become leader in ophthalmology. Of course, in the lower photograph is Professor Amod Gupta, who is my teacher. And I have documented more than 12,000 children, and I have operated so many children in pediatric over a period of 40 years. I have almost thousands of video, but I have made video of only very few hundreds of the patients. And these children, they come with the visually significant cataract, most of the time bilateral cataract, and sometimes you may see 10 to 15% of unilateral cataract. And particularly these unilateral cataract, they have at the same time amblyopia also associated. Every child which we operate, we have to dilate and to see the morphology of the cataract because it is extremely important. You may find PHPV as in the last picture here below. You may find even rubella syndrome, that child in the center, and so many other things you find after dilatation. There are so many issues of concern. Dilated slit lamp examination is must. Then whether to implant IOL or not, we have to calculate IOL power if we have to implant IOL. Then increase in the axial length is another problem because these are the growing eyes. Then sometimes there may be inflammation, and then management of amblyopia and long-term visual rehabilitation. Aim is clear visual axis, not short-term, long-term clear visual axis, and visual rehabilitation. So here I will be showing the video. These were some of the videos on pediatric cataract surgery. Fail to prepare, then you, because it is extremely important that you have to diagnose pediatric cataract, then plan, you have to innovate, execute, and extremely important is follow-up of these children. We have very, very long-term follow-up. I have a follow-up of 30 to 35 years of these children. First, I will be showing the basic step of pediatric cataract surgery. This is one of the child with zonular cataract. This is just to demonstrate that how we stain the anterior capsule with trypan blue dye, and then make the side port incision, and then make continuous curvilinear capsular axis. And this is followed by hydrodissection, and removal of the cortex from the capsular bag. And then after removal of the cortex, we make primary posterior capsulorhexis. And the size of the posterior axis is kept around 3.5 millimeter or so. If it is very big, it may be difficult to implant IOL, which is 6 millimeter optics. And then vitrectomy is done, limited vitrectomy in the zone of posterior axis. Then this is the implantation of the IOL in the capsular bag. And then whatever residual tag of vitreous or traction that is removed. Then I will be showing a few of the complicated cases, which may be PHPV, or it may be microphthalmos or juvenile idiopathic arthritis, or maybe double crystalline lens. This is another child with posterior lenticonus. This is a classical posterior lenticonus. This is anterior segment OCT. It is documented with this, and then here we perform continuous curvilinear capsulorhexis. Limited hydrodissection because we expect that there may be posterior capsular rent, and very gently cortex is removed, and as expected there was a posterior capsular rent. This was a same shape of the rent, and then IOL is implanted in the capsular bag. Then I think hardly there is any much vitreous disturbance, and this is but any of these children we have to place suture, particularly in the main section, even sometime on the side port section. This is post-operatively documented anterior segment OCT. Now this is the another child. This is posterior synecdoche all around here, and this is a JIA case. Here we have used Malaysian ring for adequate pupillary dilatation. It is important that how we should place this Malaysian ring. This gives adequate dilatation of the pupil, and continuous curvilinear capsulorhexis and removal of the cortex. This video is more than 10 years back. This was done. So that time more commonly we used to do 3-piece IOL. Although these were square as IOL, it does not matter whether 3-piece or single piece is implanted. This is another case where lenticular coloboma, 4-year-old child, and here issue is not only implantation of IOL, it is also stabilization of the capsular bag. There were posterior synecdoche, and here we have done continuous curvilinear capsulorhexis, and then hooks were applied. These are conjunctival, these were capsular hooks. There were otherwise iris hooks. They may be more sharp, edges may be there, so it is better to place capsular hooks. Then this is for stabilization of the capsular bag. Here we are placing toric IOL, and we have used Callisto here, and then these hooks were removed, and we have to achieve the perfect centration of the IOL. And then this is to show before and after surgery. And then we have this double crystalline lens. This is for few minutes. This is, I think many of you have seen this. Here we did 2 continuous curvilinear capsulorhexis on each of the lens. 2, because there are 2 lenses inside the eye, and we also designed a customized IOL for this case. This was a very big IOL, because I was also big. So each of the haptic and part of the optic was placed into the capsular bag. Central part was just aphakic, but it was covered by IOL. This is amblyopia therapy. Child could achieve excellent outcome after occlusion therapy. Now I have seen this child after 10 year or so, 10 year completed, and it went on the myopic side. Initially it was almost +2 after hypermetropic. And now this is one of the clip where there is a hemorrhagic type of PHPV. Here rhexis has been done, and we are doing cauterization of the posterior vascularized membrane. And then it is very difficult to cut with the vitrectomy cutter, so you have to make a small nick in this vascularized membrane and cut with the vena scissor, and then cauterize this stalk. This is the stalk, you have to cauterize and then cut with the micro vena scissor, and then remove this vascularized membrane. After doing a proper vitrectomy, because sometime it may be, we may not have, there should be no traction. And here we are placing IOL, which is captured into capsular bag. These are some of the other these cases of PHPV, classical PHPV. This is some very dense vascularized membrane, and these are some of the other toric and multifocal IOL implantation in children, and these are PHPV I am showing. Contribution is more than 12,000 children operated, 134 publication in pediatric cataract surgery, invited lecture almost 172 out of 510, mentoring 154 resident and ophthalmologist. This is a child which was operated by me in 1997. And now after follow-up of 25 years, now in 2022, he has become doctor, 20/20 vision each eye. Of course, he is myopic by just 1.25, or some other eye is 1.5 diopter. But reasonable that time. It is a estimated power implanted that point of time. Audio, there is only 1 minute I can take, just last 1 minute. Please continue, sir. Sure, sir. Audio. Audio lead is not. है ऑडियो लीड? इस पे तो होता नहीं है, इधर है, नहीं लगेगा, इसमें नहीं लगेगा, शायद ऐसे ही आएगा, यही होता नहीं, कोई बात नहीं. I think no issue. Oh, this was just without audio.
चिकित्सा नेत्र विज्ञान.
think this was just like one of the proudest moments when I got Padma Shri award in 2019. This was 30-second video, and just to share, this was I think two-time best of the best award at American Society of Cataract and Refractive Surgery, and third time it was a just winner award, and one time it was Oscar of Pediatric Ophthalmology. So these were some of the. This was just to show it. This was first time when I got some award at the international forum in 2012. This was also a proudest moment for me to become director of PGI MER Chandigarh without any politics or so. I gave headship to Professor Dogra, who was in age senior than me, but otherwise he was junior. But anyway, he was senior than me, so these were the other proudest moment. Okay, thank you very much.